The last chapter is chapter 11, substance use disorders. Abstinence syndrome is when the clients abruptly withdraw from a substance to which they are physically dependent. Tolerance requires the increased amounts of the substance to achieve that same desired effect that they had in the very beginning when they first used at the lower dose. Now we're needing more because they are using that substance more, so they build up that tolerance. Withdrawal is going to have physiological manifestations. Once that blood substance in that blood level drops, that's when they're going to start seeing those manifestations. Withdrawal can cause the abstinence syndrome. It depends on the substance. And then the effects of it can be distressing. It can lead to a coma and death. So they may have seizures, vomiting, nausea. Substance can be anywhere from alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, anxiolytics, stimulants, tobacco, and unknown substance. Substance withdrawal will depend, like I said, on the substance itself. So you could have GI distress, neurological, behavioral changes, cardiovascular changes that can have, depending upon what the substance is, can cause a heart attack in somebody using, and then seizures could happen with the withdrawal part of it. Substance abuse, just like the slide says, all that on there, hallucinogens, political, it could be a cultural thing, so a social peer pressure, if the children and adolescents. Medications to support withdrawal abstinence from alcohol. Effects of withdrawal is 4 to 72 hours after the last intake of alcohol. So that's very important. It's 4 to 72 hours after the last intake of alcohol, and this can continue for 5 to 7 days. Some of the manifestations that you possibly could see are nausea and vomiting, tremors, restlessness, inability to sleep, depressed mood or irritability, increased heart rate, blood pressure, respiratory rate, temperature, diaphoresis, tonic-clonic seizures, or your grand mal would be your other name for it, and then illusions. Alcohol withdrawal delirium can occur 2 to 3 days after cessation of the alcohol. This is a medical emergency. They will have severe disorientation, psychotic manifestations. They can be auditory or visual hallucinations, severe hypertension, cardiac dysrhythmias, and death if this is not taken care of or controlled. The dysrhythmias, especially in anything with the hypertension. Withdrawal, the physicians will order benzodiazepines. These are the first line of treatment of alcohol withdrawal. So this would be your diazepam, lorazepam, oxapam, chlordiazepoxy, which is your Librium. That's typically, they'll be on a scheduled. Librium, if they're typically admitted, the hospital here, we gave Librium around the clock. Intended effects, we want to obviously monitor their vital signs. We want to decrease their risk of seizures while they're withdrawing, so we may do the lorazepam or the diazepam for this seizures. Decrease the intensity of withdrawal manifestations, so that's what the Librium will do. That will help. Substitution therapy during alcohol withdrawal, so give them something else to help with those tremors, And also that's where the Librium will help as well. Nursing actions, you'd need to administer medication around the clock or PRN. Like I said, we did Librium around the clock, and the doctor weaned them off over those days that they're in the hospital. Get their vital signs, monitor definitely their neurological status, and then maintain seizure precautions. So seizure pads on the bed, and then you want to keep airway resuscitations at the bedside just in case you would need them. Okay, adjunct medications to treat with the benzodiazepines. This is management of alcohol withdrawal. Is achieved more effectively with more than one medication. So for the intended effects, the Tegretol, the Catapres, Inderal, Tenormin, so carbamazepine, clonidine, propranolol, and atenolol. Propranolol and atenolol. Those are more used for, and your clonidine as well. Your Catapres can be used for the cardiovascular system. Tegretol will be for the seizures. Sorry. Cravings, the propranolol and the atenolol will also help decrease those cravings as well. Nursing actions, you want to maintain, once again, your seizure precautions. Propranolol, you need to, very important to take an apical pulse. If it's less than 60, you do not give it. Abstinence maintenance, this is once they've withdrawn, this is now we're going to help them maintain their sobriety. Deslofrane, this is antabuse. Intended effects is they're going to take this daily. It's an aversion therapy. Used concurrently with alcohol causes acetylhaldehyde syndrome. So as soon as I've had a friend in the past who's alcohol abuse, and he just even mouthwash, I think it was, or rubbing alcohol, he smelled it and had the reaction to it. The nausea, vomiting, they become weak, flushed, headache, sweating, chest pain, palpitations, hypotension. If they drink alcohol, they'll have an immediate reaction to where they'll end up start vomiting. If the syndrome occurs, it can progress into respiratory depression, cardiovascular suppression, and seizures, and then death. So this is not something that is to take lightly. It needs to be really enforced with these patients not to consume alcohol while taking these medications. Nursing actions, like I said, inform the patients of the dangers and potential fatal reaction of drinking any alcohol. Avoid anything that contains alcohol, the cough syrups, any sauces, mouthwashes, aftershave, lotion, colognes, hand sanitizers. We'll be very surprised at what people will, when they are desperate enough, what they will get to drink. We need to monitor liver function tests for hepatotoxicity plus cirrhosis. Encourage them to wear a medical alert bracelet, so if something does happen, then they may have an idea of what they need to be treating whoever, if 911 gets called. They also need to participate in a 12-step self-help program. They don't want to alcohol for at least 2 weeks following the discontinuation of Desloframe, because it has that 2-week to where they could still go into the acetylhaldehyde syndrome. And then at least wait 12 hours after the last drink of alcohol before the initial dose of desloprame. Naltrexone, naltrexone. Sorry. This will must abstain from alcohol before starting. Adverse can be nausea, sedation, headache, and anxiety. Intended effects. It's a pure opioid antagonist, so it suppresses the cravings and the pleasurable effects of alcohol. It also can be used for opioid withdrawal. Nursing actions, once again, getting that history, concurrent use of opioids can result in withdrawal reactions. Advise client to take with meals to avoid the GI distress. Suggest monthly IM injections for the clients who have difficulty adhering to an oral regime. Acamp prostate. Intended effects, decreases the unpleasant effects resulting from absence, dysphoria, anxiety, restlessness. Client education, diarrhea can result if they drink alcohol. Maintain adequate fluid, get adequate rest. Take medication 3 times a day with meals to avoid the GI distress, and then avoid use in pregnancy. Okay, alcohol withdrawal delirium. They have severe mental or nervous changes caused by the alcohol withdrawal. They can have delirium tremors. Affects about 10 to 40% of all chronic alcoholics. They're at high risk for head injury, infection, illness, heavy alcohol use. They're diagnosed by a physical exam, laboratory tests, ECG. Tremors, mental changes, irritability, confusion, stupor, fatigue. Occurs within 2 to 3 days. So, sudden cessation of alcohol after years of heavy drinking, this can occur. Treatment by fluid replacement electrolytes. Complications, seizures, injury to self, irregular heartbeat, confusion, and then severe complications occur in about 10%. Okay, support from opioids. Withdrawal syndrome is an hour to several days after cessation of the substance use. They can be agitated, have insomnia, flu-like manifestations, rhinorrhea, yawning, sweating, piloerection. Those are the little the hairs on your arms raised. You get those little bumps. Abdominal cramping and diarrhea. They're non-life-threatening, although they can have suicidal ideations along with this. Okay, so what they're going to use to help withdrawal is methadone. It's an oral opioid agonist, which is used to replace the opioid that the client is physically dependent on. So once they get their body used to taking the methadone, what happens is that then you start tapering off the methadone and to get them off of the substance. The methadone will help prevent absence syndrome. Dependence is, like I said, transferred to the methadone then from what they were using as the opioid, and then they'll gradually taper it off. Long-term treatment and suppressive therapy is gradually increasing the dose of methadone to develop a tolerance to the point that the client gets no pleasure anymore from those opioids, and then hopefully their body and their mind will say, I don't want that anymore. Nursing actions: observe your client to make sure that the dosage is accurate to suppress those withdrawals. Slowly taper off. Encourage your client, once again, 12-step self-help program. Inform the client medications are administered by an approved treatment center. So they need to go to a treatment center to get the methadone treatment. It's not something that can be prescribed and then they get to go home and take it. So they have to be in an actual treatment center. Clonidine, intended effects, assists with the withdrawal effects related to the autonomic hyperactivity, so it calms that down. Does not reduce the craving for opioids like the methadone will. Nursing actions, once again, vital signs because it is a cardiac medication. Advise your client to avoid activities that require alertness until the drowsiness subsides. They need to, for the dry mouth, they can have gum, suck on candy, sip water throughout the day. Identify clients at risk for overuse of clonidine. Because if it's taken in a higher dose, it can cause euphoria and hallucinations. Sometimes they'll combine it with benzodiazepines, opioids, or cocaine to increase even that effect of that substance even more. So here's opioid withdrawals, what you're going to see. Sweating, diaphoresis, mydriasis, to where the eyes are going to dilate, tachycardia, goosebumps, abdominal pain, cramps. It feels like their stomach is a complete knot. Muscle cramps. And then, they say, I'm kicking the habit. I'm quitting cold turkey. Vomit, urine, diarrhea. So, buprenorphine, orphine. Intended effects is agonist, antagonist opioid use for withdrawal and maintenance. Substituted for the opioid and prevents of withdrawal manifestations. Decreases that feeling of craving and adherence for maintaining. It's safer than methadone related to decreasing the risk for respiratory depression and potential life dependency. And then it's available alone or it's combined with naloxone, which is your Narcan. This one was given sublingual. Okay, once again, so now we're going to talk about nicotine, withdrawal from nicotine. Abstinence syndrome is going to be, they're going to be irritable, nervousness, restlessness, insomnia, difficulty concentrating. Bupropion decreases the nicotine craving and the manifestations of withdrawal is the intended effect. Nursing actions, we need to treat the dry mouth with sugarless gum, suck on candy, water, ice chips. They need to avoid caffeine and other stimulants to control the insomnia and agitation. They need to avoid the use in clients who have an increased risk of seizures. And advise the clients it can cause weight loss, thus limiting weight gain and related to smoking cessation. Nicotine replacements. The intended effect is the nicotine is going to be replaced or from pharmaceutical products, substitutes for nicotine in cigarettes or in chewing tobacco. The nicotine replacement approximately doubles the success rate of smoking cessation. And then for education, avoiding nicotine products while pregnant or breastfeeding. Nicotine lozenges. You want them to dissolve in your mouth slowly, so 20 to 30 minutes. Tell them not to chew or swallow the lozenge because it needs to absorb into the mucosa. They need to follow the directions, obviously, on the package. Avoid anything orally 15 minutes prior to or during the use of the lodgings. And then they need to limit 5 in a 6 hour period, or a max of 20 in a day. So 5 within 6 hours or 20 in a whole day. Monitor for dyspepsia, which is kind of heartburn, irritation of the mouth, nausea, hiccups. Ask the client when the first cigarette is smoked each day. Higher doses are indicated for clients who smoke within 30 minutes of waking. So anybody that gets up and starts smoking within 30 minutes of getting up, they need a higher dose of whatever of the nicotine lodgings. Nicotine gum is not recommended for longer than 6 months. You chew the gum slowly and intermittently over 30 minutes. No eating or drinking 15 minutes prior to and while chewing the gum. Monitor for soreness of the throat and mouth, jaw discomfort, hiccups, and belching. And then how many cigarettes do they smoke in a day? Because the dosing is going to be based on that when you fill it out. The nicotine patch is going to apply to an area that's clean, dry, hair-free each day. They need to apply it to the upper body or upper arm. They need to change the sites each day to avoid reusing the site for at least 1 week. Advise the client to avoid using any nicotine products while on the patch. So that means no smoking, no chewing while the patch is on. Follow the directions, obviously, on the packaging. Advise the client nicotine patches can get this without a prescription. Reinforce recommended doses with the client. Typically, they're going to begin with a larger patch that has the higher amount of nicotine and then gradually decrease that over time. If they have an MRI scan, they need to take it off and for the scan, and then they can replace it. Have them watch for mild erythema, itching, burning sensation underneath this patch. And then the clients need to advise the client to stop using the patches and notify the provider if there's a local skin reaction. Nicotine inhaler, your stimulants, smoking by puffing on the inhaler, which delivers nicotine. It contains methanol, which creates that sensation in the back of the throat, similar to smoking. They need to gradually taper the use over 2 to 3 months and then discontinue. Avoid if somebody has a history of asthma or has asthma. Adverse effects is throat irritation, burning sensation of the mouth, dyspepsia, and cough. Varenicline, intended effects. It's a nicotine receptor agonist. It's going to help release the dopamine to stimulate the pleasurable effects of the nicotine. It reduces the cravings as well as the severity of withdrawal manifestations. It's going to reduce the incidence of relapse by blocking the desired effect for that nicotine. Nursing actions: instruct the client to take the medication after a meal. They need to monitor their blood pressure while taking this medication. Anybody that has diabetes mellitus needs to monitor their blood sugars, because they could glycemic control could get out of control. Follow the instructions for titration and minimize adverse effects. If they have any nausea, vomiting, insomnia, new onset depression, or suicidal thoughts, they need to notify their provider immediately. It can cause psychiatric effects, so unpredictable behavior, mood changes, thoughts of suicide. due to the potential adverse effects. This medication is banned for the use in clients that are commercial truckers, bus drivers, air traffic controllers, and airplane pilots. So once again, for review, I just kind of want to go over alcohol treatment. They're going to treat with benzodiazepines. Valium is going to be used, especially because they can have the seizures. So they can give that, or the Razapam. Opioids we're going to treat with methadone typically, and nicotine we can do the patches, the gum, and also Wellbutrin can be used for nicotine withdrawal. Alright, thank you.